So can I, yeah, thank you very much. So at the outset, I must thank AOS and Dr. Das for including me in his masterclass. It's an honor for me. And one of the cases which I'll be presenting here, I have actually been, connected.
One point.
So the incidence is gradually is increasing, and the reported incidence is 30 to 70%. But the incidence of culture negativity, as Dr. Jovita said, has come down to as low as 30%. Culture positivity has come down to as low as 30%, and negativity is almost 70%. What are the reasons for culture negativity? It could be prior use of antibiotics, scant or fastidious organisms, immune reactions to these organisms, a capsular bag sequestration, sampling errors, or maybe a sample has never been sent, as she pointed out, TAS or a masquerade, and unculturable organisms or the newer organisms that are being discussed, are being discovered. So we now have better methods of identification of organisms. One is by the PCR with Sanger sequencing and NGS, and I'll be showing you how we used NGS, the Oxford Nanopore sequencing, in our case series, and that still was negative. So this is a little busy slide, but the key points of culture negativity, as I said earlier, is that we have to make sure as to why in particular cases the negativity is coming. The approach for any endophthalmitis remains the same. What I follow now is we take two samples if we get adequate amount. We divide the sample into two. Sample 1 is for smear and curettage and culture identification, and sample 2 will either go to PCR or NGS, so that we can cover up all the aspects. And this of course means that a lot of money may need to be spent, but it's worth spending it right in the beginning so that we can treat our patients better. So I'll be showing you two cases which will tell you how culture negativity is there. So this is a 63-year-old diabetic female, and I now have a 11-year follow-up on this patient who had received 14 injections of vancomycin and ceftazidime, multiple injections of Avastin, because it was considered probably because she she was also diabetic. She got methotrexate, she was PCR and culture negative, she was PET-CT negative, and she was cytology negative. So when she came back to us, and this patient was from Chandigarh, and I was operating in Chandigarh at that time, so she worsened and presented in August 2015 with a visual acuity of 6/24. We stopped all the systemic and topical antibiotics. This patient had a well-centered IOL, and I told her that we might want to remove her IOL. Her visual acuity was that time 6/24, but she refused to get her IOL removed despite suffering for 5 years. So the question now was, should we continue giving the intraocular antibiotics and steroids, or can we do something else? We needed to have a sample. So what we did is, I tried to modify it. I thought that there could be a way of getting samples from the zonules because she had undergone vitrectomy. So we modified the thoracic 26 gauge needle, and you will see here we took the samples from the angle and samples from the zonular area. This was then sent for PCR as well as exciton, and this is just to show you the same thing. And the PCR was done at SN and exciton was done in Bangalore, and we had this Piacnes from the PCR, and exciton shows fusarium. So this is just to show that there could be, so who was right, who was wrong, we didn't bother about it. We treated both. We treated with vancomycin as well as voriconazole, both intravitreal as well as oral voriconazole, and patient till I last communicated with her till about COVID, and we probably lost her in COVID, and she was doing well for almost 4 to 5 years. So what happened, I don't know. This is case 2. This is a 34-year-old male diabetic, IDDM, who had VR surgery done, was culture negative, and he came to us after having undergone SOR. He developed a very severe throat infection, and following a throat infection which was mucopurulent, he developed probably an endogenous endophthalmitis. Some people may say that it was actually infective endophthalmitis. And this is just the sequence of things which I'm going to show you. He underwent vitreous lavage and vanco with the Tazobec and Decadron. So this is the sequence of events that occurred to him over a period of time. On 13th June, he had a repeat surgery. This is how initially the fundus was not seen. You can see the fundus now. The visual acuity improved to 6/6 until now. When I saw him last on 29th August, he was doing well with the good visual acuity. So this is the sequence of ultrasounds for this particular patient. When he presented to us on 2nd June, he had, this is a vitrectomized eye, so he had this opacities of moderate intensity. And then he subsequently underwent vitreous lavage, multiple drug injections, which included vanco, Tazobec, and on the second time he underwent injection of colistin. I also did a wash with betadine, and the patient is doing well. He still till today has few vitreous opacities. I don't know what the cause is, and we have stopped all treatment for him. His visual acuity is 6/6, is doing well. So this was a case of culture negative endophthalmitis which received multiple antibiotics at one go, which Dr. Lalit asked, can we combine more than one drug? Yes, in some cases of severe endophthalmitis, it may be necessary to combine more than one drugs to get the desired effect. So in the end, what I would like to say that next generation sequencing is there to stay. We have to judiciously use it. Organismal diagnosis is important and helpful. And case 1, you saw that despite the PCR and NGS, we could have, that time NGS was not available, but PCR and culture gave us a diagnosis and we were appropriately able to treat. So sampling of the correct sample is important, and in the second case, as I showed you, that use of multiple drugs, use of betadine lavage, and a close long-term follow-up in these cases is important. So you must start with empirical treatment, which at this point of time may be vancomycin and Tazobec for me. Later on, I may add colistin. There should be a timely and a judicious use of appropriate antibiotic, timely intervention with the vitrectomy, and we must be aware of the bacterial resistance. So therefore, we must be ready to change the antibiotic.